Knock knock. I'm Sarah, I'm your nurse today. I'm going to wash my hands. And I'm going to apply gloves. Okay, Miss Ford. So, quick QSIN. I'm going to check wristband. Miss Ford, correct date of birth. The whiteboard is up to date with physician and PCA and nurse. Right date. There's no oxygen. I am noting an EVD drain on the left side. There seems to be some pink drainage in the container. There's no chest tubes, no trach, no Foley. There's a left IV, left anacube IV, saline locked. Bed is in the lowest position. There's 3 side rails up. The call light is within reach. Patient assistive devices are within reach as well. And there is no clutter in any kind of pathways. And there is no cup in here because she is NPO. And the commode is in the corner. So, Miss Ford, I'm going to go ahead and do a head-to-toe assessment on you and get some vitals. And she is unresponsive right now. Miss Ford, because she's intubated, I'm sorry. So we're going to go ahead, instead of doing orientation questions, we're going to do the Glasgow scale. So, responsive to eye opening. She is unresponsive to eye opening, so that's going to be a 1. No verbal response, so that is also a 1. So now I'm going to check to see if she responds to any type of pain. So I will press on her nail bed, and she does react to pain there. So then I'll also confirm that with a sternum rub. And she does flinch with pain there. So that's going to be a 4. So her Glasgow scale is a 6 right now. I'm going to move on. Facial symmetry, nice and even. There is some bruising on the left side. Eyes, I'm going to use my pen light. Equal and reactive. 4 millimeters, and they're round. Lungs and heart. So listen to the lungs first, and she's vented right now. So what we're looking for is for her respirations to be in sync with the vent. We're going to listen to the heart. S1 and S2 are present. Lungs are clear bilaterally, and it is in sync with the vent. I'm going to go ahead and pause. I should have done the vital signs first. I was getting nervous hopping into it. So, vital signs. I'm going to grab my vital sign machine here. Alright, so temperature 98.9. Oxygen 95%. Respiratory rate is 16 on the vent. Heart rate is 84, and then blood pressure 124/68. So we're going to hop back in to our assessment. She does have a OG, orogastric tube in, so I'm going to be sure that is clamped and not connected to anything before we lower her down. so I can listen to her belly. Alright, we're gonna look first and then listen, sorry. Getting ahead of myself. Okay, soft and non-tender. Skin is nice and warm and pink. Dry and intact as well. Alright, we're gonna go ahead and sit back up. And I'm going to turn your head this way a little bit, looking for JVD. There is no JVD present. Turn your head that way. There's no JVD present. So we already checked for pain response, but now we're checking for cap refill. Good, and that's less than 3 seconds. Fingers are nice and warm. Checking for radial pulse. Be sure that they're equal, which they are. And then we're going to go ahead and check pedal pulses as well. Good, and we're going to check our cap refill. Patient is unresponsive right now, so we can't check for any numbness or tingling. I'm going to go ahead and change my gloves, wash my hands, put new gloves on, finish our assessment. If they'll go on. So Miss Ford came in with a left parietal lobe epidural hematoma. And she's in the ICU, so that's where we're at. Okay, I'm going to check some skin turgor here really quick. So nice and elastic, as it should be. Alright, so I'm going to check some orders. This looks like we have a Foley to be placed. Okay, so we're going to go ahead and get our supplies ready, which I don't actually have, so I'm going to verbalize the entire process. I would have a Foley kit, French 14. I will be sure that her OG is clamped and not connected to anything before laying back a little bit. Going to remove our pants. To wash my hands. I'm going to explain the procedure to the patient. Ms. Ford, you are getting a Foley due to being intubated with your lack of, or I'm sorry, not lack of, due to with your immobility. So, so we're able to drain your urine. Standard. So I'm going to provide privacy, close our curtain here, make sure the door is shut. Position patient with the knees bent. So I'm going to call on a friend if I need some help since she is intubated and unresponsive. Knees up. So I have access to her bottom area. I'm going to don sterile gloves. So open up the sterile gloves. Open up our sterile gloves. So there's one sterile glove. There's the other sterile glove. We're going to place the sterile drape under the bottom. So we're going to have my friend help me lift her bottom up, place that drape underneath there. We're going to fill our retention balloon with 5 milliliters of water. 5 milliliters of water. Check the integrity of the balloon. So inserting the water, pulling it back, withdrawing it, putting it back down. We're going to lubricate the catheter tip with our lubricant. We're going to clean the perineum. So we're going to use our soaked swab or soaked iodine swabs with our tweezers. So dirty hand, clean hand. We're going to wipe the labia, outer labia, trash, outer labia, trash, inner labia, down, trash, inner labia and down, trash. Maintaining separation of the labia, dispose. Now I have my hand here still. I'm going to grab the catheter tip. I'm going to insert it. I'm going to keep inserting it until there is urine, and then 1 inch after that. I'm going to use this hand to hold it, and I'm going to insert the water into the balloon. I'm going to lightly tug back to see if the balloon is inserted correctly, and it is. So I'm going to remove my gloves, put them in my trash. I'm going to come over here, drape the bag over the bed and attach it to the piece, attach the hook to the frame, being sure that it does not go under her leg or under anything else that would clamp the tube, so we're not restricting any urine flow. We'll leave these off. We'll just simulate that these are legs. So, over. There we go. That makes more sense. So, tube is over the leg, attached to there, underneath the frame. We're going to then document the procedure. Date time, so today is May 21st, it's 10:28. Reason for catheterization is immobility due to being intubated and unresponsive. Type of catheterization is indwelling catheter, 14 French, 5 milliliters into the balloon, and the urine output from the insertion is clear, light pale yellow, and the patient tolerated it well. There was no sign of pain response, although she is unresponsive. So go ahead and wash my hands. And I'm going to, an hour has elapsed. There's 120 milliliters of urine in here. We're going to go ahead and check our orders again. So orders are to have normal saline run at 75 milliliters an hour and tube feed 40 milliliters an hour. So we're going to go ahead and get that started. Does that sound good, Miss Ford? Okay. So first we're going to make sure that she is in a nice position. Can't be laying flat with a tube feed. So semi-flowers position. I'm going to wash my hands, gather my supplies. So we're going to pretend that this bag is in fact larger and normal saline. So we have our IV site in our left anacube, So I'm going to bring your arm over here a little bit. We're going to hang our bag. Well, we won't do that yet. We'll wait. Alright, so gloves on. I'm going to clean the IV site. And this is sterile as it just came out of a package. So we're going to, oops, hold on. Actually, before that, we're going to, this is already flushed, but I'll verbalize it anyways. So we're going to be sure that our line has no bubbles and is flushed. Or primed, not flushed, primed. Alright, so there it is. We can wipe off this if we need to. Alright, so that is all wiped off and sterile. Now we will attach it to our saline lock. Tape it to the patient's arm if needed. And then we will hang it as it in the IV machine, IV pump. Set it for 75 milliliters an hour. Right, then we're going to go ahead and do some tube feeding through the orogastric tube. So we will set our pump, our feed pump, to 40 milliliters an hour. Hook that up. It is running. We're going to, then we'll come back in an hour. Wash my hands. Alright, wash my hands, Miss Fords. It's been an hour. Coming to check on you again. Your urine output is 240 right now. Everything else looks good. IV site is nice. Looks nice right now. No issues there. Foley is still in place. No issues there. I'll come back in and check on you in 1 more hour. Wash my hands. Alright, knock knock. Wash my hands. Sarah again. Alright, Miss Fords. I'm taking a look at your urine out of your catheter bag. Looks like we have an additional 440 in the last hour, and it is pretty clear, pale yellow, large amount. So I'm going to go ahead and recheck your blood pressure. I'm going to wash my hands again. Recheck your blood pressure. This time it is 108 over 56. And let's check your heart rate. 104. And then with your EVD, intracranial pressure is 15. So it's elevated a little bit more than what we like to see. Some lab is going to come in and draw some blood, check your sodium, your osmolality, and then we're going to take a sample of your urine and check the specific gravity of that. Okay? Alright, I'll be back. Wash my hands. Alright, knock knock. Wash my hands again, Sarah. Okay, so let's look at your results from your lab work. Your sodium is 155, which is high. Osmolality is 310, which is high also. And your specific gravity, urine specific gravity is 1.005, which is on the low side. It is low. So it looks like we have some orders from the physician here. We're going to free water flush your orogastric tube, 200 milliliters every 4 hours. We're going to change your IV fluid, the normal saline fluid, to D5W, and we're going to run that at 125 milliliters an hour. And we're going to change that because your sodium is high. We have an order here for desmopressin, 2 micrograms IV push every 12 hours. We're going to check your weight daily, and every 4 hours, somebody from the lab is going to come up and draw some blood. We're checking your sodium and your osmolality. So I'm going to set the pump to set your feed pump to administer the free water, and then I'll change your IV fluid from the normal saline to D5W while I wait for pharmacy to bring up the desmopressin. Okay? And what we're doing whenever we're changing the feed to free water is we are attempting to replace the water that you have lost due to your head injury. It seems that it seems like you have diabetes insipidus right now, because there can be some damage to the pituitary gland. The pituitary gland is what produces ADH, and if that is damaged, it can cause your body to have a lack of that's what we want to see, okay? So I'm going to go ahead and get that ready. I'm going to wash my hands, put gloves on. I'm going to check the medication vial against the medication against the med order, and it does match. Okay. You are Miss Ford. You are 32 years old. This is prescribed for you. IV push. So we're just going to withdraw the solution itself and not dilute it down. You have we're gonna inject. We're gonna pause your D5W. I'm sorry, no, we're not. We're going to insert it into your line right here where there's a port that we can push through. So I'm going to go ahead and get that ready. Wash my hands. Withdraw 2 micrograms of, well, let's assume 2 milliliters of air, which would be 2 micrograms of medication. 2 milliliters of air. Going to take our container, our vial, inject 2 milliliters of air into the container. We're going to withdraw 2 milliliters of medication while maintaining plunger sterility. And there's 2 milliliters, making sure we don't have any air bubbles. We're going to then put our medication down, which we did wipe off the vial with an alcohol swab very thoroughly. I am going to take another alcohol swab and wipe off this port. Be sure it's nice and clean. Okay, and then we are going to push our desmopressin over 1 minute, checking for any signs of redness at the IV site, any reactions, any indication of pain. Okay, 1 minute has elapsed through that. Alright, so I'm going to go ahead and walk out, wash my hands. Alright, knock knock, wash my hands. Alright, Mrs. Ford, this is 2 days later. Your urine output and your urine specific gravity have returned to baseline. Although her glaucoma scale still remains between a 4 and 6. Left pupil is 8 millimeters and fixed. Respiratory rate is erratic. Intracranial pressure is 18, so that is increased, and your heart rate is dropping. So this is report off time, shift change. So Michelle is going to come in. She's going to be your nurse for the remainder of the day. Michelle, this is Miss Ford. She's 32 years old, female. Came in 4 days ago due to a large epidural hematoma on the left parietal lobe. She was intubated due to low level of consciousness and to protect her airway. EVD was placed left side to monitor her ICP, intracranial pressure, and drain fluid. There is pink clear fluid draining from that. Let's see, she has a orogastric tube and a Foley catheter as well. Which we placed here. She's getting desmopress and IV push every 12 hours. It has D5W running at 125 milliliters an hour in her left anacube. She was connected to tube feed at 40 milliliters an hour, but we did switch that to 200 milliliters of free water every 4 hours. So that is what is in the feed pump now, and that is what is ordered. She has a daily weight. We're going to need to check her weight every day. We can do that on the bed. Her urine output and specific gravity have returned to baseline. However, her glaucoma scale remains between a 4 and a 6. Her left pupil is 8 millimeters and fixed. Respiratory rate is erratic, and heart rate is dropping. Her last intracranial pressure check was 18, which is high. We've been turning her every 2 hours to rotate. There's no sign of skin breakdown. Last set of vitals were fine other than the heart rate dropping and her respiratory rate. And the doctor was made aware of that. Okay? All right. Thank you, Mrs. Ford. I hope you have a good day with Michelle, and I will see you later.